Welcome back to Lungcast, the monthly respiratory health podcast series from the American Lung Association and medical news site hcplive.com. I'm your host, Dr. Albert Rizzo, the Chief Medical Officer of the American Lung Association. Before we introduce our topic and our guest today, just a reminder that Lungcast is available on all your favorite streaming platforms. Subscribe to @Lungcast on YouTube to get new and archived episodes, as well as interview segments and episode highlights as they come out. A link to the show page, as well as the American Lung Association and hcplive.com homepages for Lungcast, can be found in each episode description. For those of you who prefer a podcast, you can subscribe to Lungcast on Spotify, Apple Podcasts, and your favorite listening platforms. You can also register for more respiratory news and insights at both lung.org and hcplive.com. Cancer of the lung remains the number one cancer killer of men and women globally. In 2024, lung cancer was responsible for 1.8 million deaths, which is 18.7% of all cancer deaths. There are two major categories of lung cancer: non-small cell and small cell lung cancer. Over the last 2 decades, we have seen advances in diagnosis and therapy, especially of non-small cell lung cancer, with the introduction of lung cancer screening that detects early-stage disease where survival is much more likely, and also with the explosion of targeted therapies and immunotherapy checkpoint inhibitors, which have extended progression-free survival in many cases of non-small cell lung cancer. However, small cell lung cancer, which represents about 15% of all lung cancers, has not seen similar successes. Small cell lung cancer is a highly aggressive lung cancer characterized by rapid growth and early metastasis, often spreading to other parts of the body like the brain, bones, liver, and most patients with advanced disease at the time of diagnosis are seen, typically requiring multimodal treatment. To discuss more deeply this cancer and to bring us some encouraging perspectives on the current state of therapies for small cell lung cancer is Dr. Jacob Sands. Dr. Sands is a thoracic medical oncologist at Dana-Farber Cancer Institute, where he also serves as Associate Chair of the Lowe Center for Thoracic Oncology and is Assistant Professor of Medicine at Harvard Medical School. He also joined the Dana-Farber Cancer Institute in 2017, where he sees individuals with lung cancer and leads the small cell lung cancer clinical research program. Dr. Sands has published several manuscripts on lung cancer and is leading many active clinical trials treating lung cancer. He's a member of the National Comprehensive Cancer Network, or NCCN Guidelines Committee on Small Cell Lung Cancer and Lung Screening. Despite keeping busy with patients and these other duties, he finds time to act as a volunteer medical spokesperson for the American Lung Association. Thank you for being with us today, Dr. Sands.
So happy to be here. Thanks for having me.
So the staging and the terminology for small cell lung cancer differ a bit from non-small cell lung cancer, in which there's 1 to 4 stages which indicate early or advanced diseases. Small cell lung cancer is divided into limited and extensive stages. Please review these definitions and the evaluations necessary to complete the staging.
Yeah, so we do have stage 1 to stage 4, much like in non-small cell lung cancer. But more commonly and kind of clinically, we discuss this as limited and extensive stage. Now, essentially, limited stage is ultimately what is limited to a hemithorax and nodes that can all fit within one radiation field safely. And so when you're really at the cusp of what is limited and extensive stage, that certainly requires the input from radiation oncology. Now, we do have really early stage small cell lung cancer. It's just not very common. So a solitary lung nodule and maybe a hilar node, that's the kind of scenario where patients could undergo surgery as their initial therapy. The hilar node being that area for real discussion. That's N0 or N1. But I think beyond that, then we're really talking about concurrent chemoradiation as the treatment. And if something extends beyond what is feasible within a radiation field, then that by definition is extensive stage. And then we're talking about palliative treatment in the sense of treatment with a goal of improving and prolonging one's quality of life.
So before we get into the specifics of the treatment, when discussing non-small cell cancer, we know there's an importance of genomic patterns and biomarkers that are evaluated in helping to identify appropriate therapies, such as EGFR and ALK, RET, ROS1, and MET, and on. Targeting genetic mutations in non-small cell lung cancer helps to improve outcomes. Is there a role for this approach in small cell lung cancer?
The short answer to that is no, but yes, which sounds confusing. So let me explain.
Great.
Broadly speaking, no, we don't really see these actionable genomic alterations in small cell lung cancer, but in individuals without a smoking history or a limited and distant smoking history, we do sometimes see these show up. And I think what that speaks to is likely a de novo small cell transformation. Now, the most common for small cell transformation is non-small cell adenocarcinoma with EGFR mutation that is on targeted therapy. And one of the ways of getting resistance is through small cell transformation. Now, that being said, I have seen a case of EGFR mutation that's small cell de novo. I've also seen Medexon 14 skipping mutation and others. So it's really quite rare. But in somebody without a smoking history, this is an important thing to check for.
Great. So radiation and chemotherapy have been the mainstays of therapy for small cell lung cancer over the last several decades. Now, despite initial good response to therapy, recurrence and systemic spread are common, and the 5-year survival for small cell lung cancer remains low, with median survivals in the 2 to 4 month range after diagnosis and a 5-year survival at a rate of about 5 to 10%. As we begin to talk about therapeutic options for small cell lung cancer, let's start with the approach to the patient with limited stage disease. What would be your current therapeutic landscape?
Well, we've recently saw an advance in this arena. Limited stage small cell lung cancer for a long time has been treatment with platinum etoposide and radiation as concurrent therapy. We just recently had the Adriatic data last year, which showed that when incorporating 2 years of durvalumab after the chemo radiation, we saw an improvement in the median progression-free survival by 7.5 months. We saw an improvement in the median overall survival by 22.5 months. Now, although those numbers sound astonishingly higher than what we saw in the extensive stage setting with the incorporation of durvalumab, which is the Caspian study, in that study, no real change in the median progression-free survival, an improvement in median overall survival by 2.7 months. So again, in a limited stage now, 22.5 month improvement in median overall survival. Despite this astonishingly higher and seemingly much better benefit, it really is just because of where the curves are on that graph and the separation of the curves from Caspian as compared to Adriatic are really quite similar. So we see in limited stage disease, the number of patients that have durable survival and disease control is drastically better than extensive stage. Of course, we already knew that. We know that the earlier stages are going to have better outcomes. So in the extensive stage, that control arm of just platinum etoposide for progression-free survival really just drops off. And the tail of that curve, as you get further out in time, goes down to basically just about everybody having progression of disease. Now, in the limited stage setting, the tail of that curve, it's about a third of patients 2 years out that still have ongoing disease control. So, we are curing close to or somewhere around a third of patients from just platinum etoposide. When we add in durvalumab, that improves by another 12%. 2 years, about 46% of patients with ongoing disease control. So what we're seeing with the median is that one horizontal line through the chart makes it seem like much more, but it's kind of the way that curves are. In the overall survival, the steepness of that curve, in the number of patients that are dying earlier on. That steepness improves. It's more level. So patients are not dying as quickly, which is relative to that earlier stage diagnosis. And so we're seeing a number of patients that have survival further out. So at 3 years in the control arm, about 48% of patients are still alive. In the arm with durvalumab, that improves by about another 12% as well. Now, the really encouraging thing from this is that what we see in the tail of the curves in the extensive stage setting is that with immunotherapy, we are having, it's a subset, but a meaningful number of individuals that are getting years of disease control. And when we move it into the limited stage setting, where the goal is cure, again, we're seeing a tail of the curve that suggests that we're getting more patients into that more durable time. Now, we need another 5 years, 3 years of time to see, okay, how did that result in cure rate, which we typically talk about as 5 years after treatment. But with the immunotherapies, maybe even further beyond in seeing how many patients does it look like we really cured. But this data that we have right now is exciting and has across the board really led to a change in the standard of care in the limited stage setting.
Definitely progress in small cell based on that.
That's right.
So as I mentioned earlier, the disease often spreads outside the chest. And I understand that once the disease is controlled in the chest, the brain is still a concern. There's roughly 60% chance of recurrence in the brain within that first 2 to 3 years. And the brain metastasis is often the cause of death in some of these patients. For this reason, can you describe the role of prophylactic cranial radiation in the treatment of small cell lung cancer?
Yeah, this is a complex topic now. So historically, for small cell lung cancer, both limited stage and extensive stage, the standard of care was to give prophylactic cranial irradiation after platinum-based therapy. Now, the big challenge to that, which maybe wasn't appreciated so much at the time, but is quite a bit now, is that there was not an MRI brain at baseline. So it was called prophylactic cranial irradiation because there was no known cancer in the brain. But our current standard of looking for cancer in the brain was not met in these earlier trials, meaning that it's plausible and I think very likely that there were individuals that had active brain metastases. But if an MRI brain had been done, then that would have been known. Well, now we do MRI brains all the time for this stuff. So, now we can know. So the likely, or the question then is the benefit really just therapeutic treatment of brain metastases that were not diagnosed? Now, we have a study from 2017 that was done in Japan looking at prophylactic cranial irradiation or observation with an MRI brain every 3 months. And this is in the extensive stage setting. And what we see from that is kind of a flipping of the curves, that if anything, it looks like the patients that didn't get radiation to the brain actually survive a bit more. It's a trend, we can't say conclusively statistically speaking that observation is actually better, but there's certainly a trend toward better, meaning that we're really not seeing even a hint of improvement from getting prophylactic cranial irradiation. Now, what that has led to is real questions of, was this prior truth, I'll put in quotation marks, was it actually true, or was it just that we didn't have the diagnostic ability in earlier on or utilize MRIs, and therefore we're not able to tease that apart? So now there's been more of a trend toward doing an observation MRI every 3 months instead of prophylactic cranial irradiation in the extensive stage setting. Now, in the limited stage setting, this is still a huge question mark because we don't have any data in the limited stage setting with MRI brain every 3 months. There is an ongoing trial called the Maverick trial through SWOG, which is a randomization to MRI brain for observation or prophylactic cranial radiation in both the limited and extensive stage settings. This is accruing, and hopefully from that trial we'll get a bit more guidance on this. I think one way you could look at this and say, okay, in the extensive stage setting, we had this prior, again, truth in quotation marks, that we found doesn't actually appear to be true when we're doing an MRI brain at baseline. So what kind of implications does that have for this, again, truth in quotation marks in the limited stage setting? Does that mean that that's also not true? We don't know. The Maverick trial will hopefully give us validation in the extensive stage setting, and will give us some of our, only data in the limited stage setting as to whether prophylactic cranial radiation is worth it. Now, at the same time, there are advances in PCI, in prophylactic cranial radiation, or PCI for short. There are advances in PCI in that we now do hippocampal sparing, so that may help in reducing any kind of memory side effects. There are also some medications that can help to prevent memory loss in the process. And so this is very much an evolving field. Now, it has had implications downstream, though, in there being a higher likelihood of brain metastases showing up further on. If patients have not gotten PCI, that means they've not gotten radiation to micrometastatic disease in the brain, and therefore may have brain mets show up down the line. Now, that's somewhat of a new paradigm in small cell lung cancer as we shift away from PCI. And so how to treat that becomes another area for discussion. And for those who are on immunotherapy and have something show up in the brain, but otherwise systemically doing well, then I have those radiated and I continue their systemic therapy. And I guess I've specified immunotherapy, kind of the maintenance in limited stage or maintenance in extensive stage. But even beyond that, for patients that are then on a line of treatment, if they have brain-only progression, we now also consider SRS, or a very focused radiation, to those brain mets instead of radiating the whole brain. But just radiating those spots and then continuing the systemic therapy in depending on the scenario,
Right.
is also a viable option.
As you mentioned, complex. Hopefully some answers in the next few years.
Yeah.
So I wanted to go back to the treatment again. You've already touched a bit on durvalumab. I also wanted to have you touch on some of the newer treatments, the immunotherapy agent tarlatamab, and I believe there's also another chemotherapeutic agent, lurbinectedin, if I said it correctly.
Yeah, both of these are the advances that we've had in the last 5 years. So lurbinectedin, published in 2020 and led to FDA approval in the second line. That was based upon a 105 patient cohort in a basket trial, but 105 patients with small cell lung cancer in the second line setting treated with lurbinectedin. Now, what we saw from that was a 35% response rate, a median progression-free survival of about 3.5 months. Median overall survival, I think, was 9.3 months. And now that trial is a little different than the other small cell studies in that it did not have a limitation in the chemotherapy-free interval, meaning that patients with less than 60 days of since their initial platinum-based therapy who had progression, those patients would not have qualified for the topotecan study that led the first topotecan study leading to topotecan approval as second line in the IV form. That is a worse prognosis scenario. Those patients were eligible to go on lurbinectedin, which is just to say that the numbers that I just mentioned, that includes this really poor prognostic group as well. Now, the outcomes I report that I mentioned, obviously we need to still keep doing research. I don't think anyone feels like the work is done, but once every 3-week infusion, pretty well tolerated. I mean, as far as side effect profile, yes. I mean, this is chemotherapy, but I'd say better tolerated than the platinum etoposide, certainly. Patients don't lose their hair with this regimen, which I think is actually a bigger deal for more patients than they want to voice. But it's not just a matter of vanity. It's how people are treated by others around them as well, and whether they suddenly lose their hair and now people see them as somebody getting chemotherapy versus looking like the person that they've known for a long time. So it goes beyond vanity. But aside from that, even generally fairly well tolerated and manageable toxicity profile. Now, the other thing about that I'll point out is I actually really like the 6-month progression-free survival, because in the second line setting, it's tragic that this is true, but that's a meaningful time frame for a second line regimen. And in those with a short chemotherapy free interval, more platinum resistant disease, that's the group that's really hard to treat, that other chemotherapy regimens may not work. 6 months of disease control in about 19% of patients. So that's an unfortunately low number, but it does represent that about 1 in 5 had disease control for about as long, if not longer, from their second line therapy as they did from their first line. That's meaningful. In those with a chemotherapy free interval of 90 days or more, 44% of those individuals had at least 6 months of disease control. So a bigger number of patients. I think that's a promising number. That's encouraging to see. So this became my second line standard of care at the time that was reported out and approved. Now, more recently, we have tarlatamab. Tarlatamab was initially published in the New England Journal. It was FDA approved last year. Now, in that study, 2/3 of patients enrolled got it as third line therapy, and a third got it as fourth line and beyond. Now, because the data is so good, it got FDA approved in the second line and beyond. And so I'll tell you that data. The response rate was 40%. There were an additional 30% that had stable disease. Now, in non-small cell lung cancer and some other tumors where the cancer doesn't grow as aggressively, stable disease, it could be growing slowly and then it's still stable disease. But small cell lung cancer doesn't tend to grow slowly. So some portion of stable disease is often individuals that are benefiting. In this case, there's a decent percentage of patients that are getting 5 to 6 months of disease control. So when I talk with patients, I often say there's about a coin flip's chance that they benefit from tarlatamab. 40% response, some portion of that 30% with stable disease are getting benefit from this. Now, the median overall survival for this as a third line and beyond was 15.2 months. And in the 40% that had a response to treatment, 43% of those individuals were still actively on the drug at the last data cut, which was more than a year into the treatment. So all of that is to say, we're seeing a pretty good response rate from the drug, and we're also seeing on the tail of the curve real durability to that response. And so this has been all very encouraging, and now tarlatamab has been pretty quickly moved into the treatment paradigm. The challenge to this is that the first 2 doses can cause something called cytokine release syndrome. And a drug called tocilizumab is an important rescue for anyone who's having real clinical decline from that. It's hospitalization for those first 2 doses to be monitored closely for cytokine release syndrome. And so as of right now, it's mostly the big academic centers that have this drug available. Although there are many community sites across the country, but not as many percentage-wise, and it is still being rolled out across centers. So in many cases, it's very important for individuals to be evaluated at one of their closer academic centers to see, is this something that can be given, or for community sites that don't have it already available, to be working with those larger centers that are offering this as a line of therapy.
The cytokine storm became in the news during COVID outbreaks back in the 20s, and tocilizumab was Tosi is the treatment for that, as you mentioned.
Yeah, that was my first experience actually, was during the COVID waves here in Boston when serving on our inpatient service, taking care of patients with COVID who had cancer, is using Tosi in that setting. And now for cytokine release syndrome in this setting.
The tarlatamab as an immunotherapy drug, how does that compare to the durvalumab? What's the role of those two drugs?
So durvalumab and atezolizumab are both PD-L1 inhibitors. So essentially blocking the receptor on the tumor cells that speaks to immune cells saying, hey, I belong, chill out, and kind of um, calming that immune response. By blocking that interaction, we get a better immune response. Now, that kind of immune response in small cell lung cancer, I'd estimate, it helps in maybe 20% of cases, but of those who have a response to the immunotherapy, that can be very durable. And so we have in the third line setting, pembrolizumab. Now, initially Pembro and Nivo were both accelerated approval in the third line setting as single agents. And so the PD-1 obviously being the receptor binding the PD-L1 on the immune cells. So the with Pembro, it was a 19% response as a single agent, but 13% with ongoing disease control at 2 years. So lower response rate, but incredible durability. Tarlatamab is a bit different. It's bispecific T cell engager, so it binds DLL3 on the tumor cells and CD3 on T cells. And by binding both of those, it's essentially introducing the immune system to the cancer to then create this immune response. And as I said, 40% response rate. We don't yet know if that durability is going to hold up like what we've seen from durvalumab and other checkpoint inhibitor, PD-1, PD-L1. We're going to need some more time for those curves to mature, but the initial look is quite encouraging for that.
Great. Thank you for that explanation. So I wanted to touch one more topic. Based on the current state and some of the limited success with the aggressive disease, I know there's been other options being pursued in the way of treatment, and specifically the development of vaccines for treating small cell lung cancer. In preparing for this talk, I know this goes back to the early 2000s. There was research into this area, and the American Lung Association actually is co-funding a researcher along with the Gateway for Cancer Foundation, looking at developing a personalized vaccine to use neoantigens to treat the immune cells and recognize small cell lung cancer. I think there's also something called polyvalent vaccines that are being looked at. Can you have your thoughts on the current state of this vaccine approach to treatment?
Yeah, this is something that has been kind of chased or pursued for a while now in different ways. But ultimately, this is an effort at creating that kind of immune response that I was describing as being so durable. The cytotoxics, the chemo regimens, when we use those and they're effective, generally speaking, they're effective for months, not years. What we see from immune responses is that an effective immune response can be effective for years. And that is really the power of the checkpoint inhibitors so far. What I'm hoping we will see from tarlatamab, as we've discussed. And then these vaccines are a way to really make it personal to that tumor. So basically what it's doing is trying to find a way to train the immune system to recognize the specific markers on each individual cancer. So I described tarlatamab. It's a bispecific T cell engager that's binding DLL3 on the tumor cells. Now, that DLL3 is very common on small cell lung cancer, and therefore it's a good target. But wouldn't it be better if we could make sure that we have more than one receptor even on that tumor, personalized to each individual tumor, so that the immune system really knows what it's looking for, so to speak, and that the immune system can effectively find the tumor cells anywhere that they are, and then kill those tumor cells. And so this personalized vaccine is a way of doing just that. I commonly get asked by patients, well, what if you just do surgery or just radiate all of these different sites that are seen? And so what I'm often explaining is I like to speak in analogies with patients. And so one of them that I commonly use is saying that these scans, as amazing as the technology is, and it still blows my mind that we can look inside people's bodies with these scans. But as amazing as that is, it's kind of as if we're in outer space and looking at the earth at night. And being in Boston, I'll say we can see Boston light up, we see New York City, but there may be some towns or villages in Western Massachusetts that are smaller, where there are people there are lights, but not enough for us to see from outer space. And that's kind of like our scans. But your immune system goes everywhere, and the chemotherapy goes everywhere as well. The other immunotherapies go everywhere. But if we can train the immune system to effectively find all of those cancer cells, then that adds a whole other layer to that immune response. Now, I mean, if we can get an effective immune response, we know that there can be real durability to that. And so these vaccines are essentially an effort to do that for every individual cancer, because it is, it's built based upon each of those cancers to develop the vaccine for that individual, for that person, and that cancer that each individual has, to create an immune response to those.
I really like that analogy you use. It's great. So before we close, are there any other aspects you'd like to touch on or talk about any of the current research going on at Dana-Farber?
Well, there is so much going on in small cell lung cancer. So not just at Dana-Farber. I mean, we have a number of trials open that I'm very excited about. We have a CAR T trial, which is essentially taking immune cells, kind of like when people donate blood or donate platelets. They have the blood taken out, and then a centrifuge spins it down, and then you can pull off a specific layer of that and then give all the rest, give the blood back. But we can pull off a layer of immune cells, and then those cells can be processed to find the cancer as well. And so patients then get those cells back after they've been processed to then create this immune response in the same ways I've been describing. We currently have a trial open that is a CAR T in this way. That's a very exciting study that I'm very happy to be a part of. But broadly, there are antibody drug studies, antibody drug conjugate studies that there are multiple that have been really promising, that are now being studied in larger studies as well. So ifinatamab deruxtecan is a B7H3 antibody drug conjugate. Antibody drug conjugates are essentially compounds with an antibody that binds to receptor on the tumor cells that leads to internalization of the compound, where the payload is then released. So it is a lot like a targeted chemotherapy, is often the way that I'll discuss it. Ifinatamab deruxtecan go into B7H3. ABBV706 is a SEZ6 antibody as well. Both of these have shown response rates at about 60%, which is incredible in patients who have already progressed on first-line therapy and later-line therapies. That kind of response rate we have not seen from other regimens. And so this is exciting. These are moving up earlier on as well. There are other immunotherapy type drugs. We have a CD47 and DLL3 bispecific as well. I mean, this is scratching the surface. I guess the point being that there is more going on right now in the development of drugs for small cell lung cancer that looks encouraging, that looks exciting, than the culmination of everything up to this point so far. And the science is getting so fast that I think in the next decade ahead, we're going to see some very big advances in the field. And I'm just so optimistic looking forward. Now, that's not even touching on the biomarker stuff, in that we have a whole framework now of proposed subtypes that may help us go even deeper into small cell lung cancer as we categorize out subtypes of small cell that are driven by different mechanisms that we may be able to target even further. There's a SWOG study in the first line that is based on subtype in the maintenance setting to have different treatments for different subtypes. So there, Al, if we talk in a year, there's going to be so much more to discuss.
Well, as I said at the beginning, you were going to give us encouraging perspectives, and I think you have. This is a great message to end on. So I want to thank you again for the time today, and certainly for all the volunteerism you have done for the American Lung Association as a national spokesperson. So to our listeners, if you want to hear more regarding all things respiratory related, we have a great archive of discussions on our show feeds. Be sure again to subscribe and rate Lungcast on your preferred listening or watching platform, and visit lung.org and hcplive.com for more news and resources. And until next time, I'm Dr. Albert Rizzo reminding you that if you can't breathe, nothing else matters.